इसमें है चंद्रकांत। At the crest of the alveolus is pencil thin, and say on the left side I think we have sufficient width of the bone and height is not a problem. So I'll start with an incision. I have given local anesthesia, bilateral inferior alveolar nerve block, and I have given some infiltration so that I'll give a crestal incision. If any queries in between, anyone can ask me the questions so that it can be a interactive discussion if incision is proper or not. So I think I reached. Can you see it properly now?
Yes, sir.
What I am exactly doing, okay?
Yes, sir.
This is what I have started, initial reflection of the mucoperiosteal flap with the sharp end of the mucoperiosteal elevator, okay?
Yes.
Is it clear now?
Yes, sir.
Yeah?
Yes, sir.
Great. Dr. Santosh, please come.
Now is okay, sir?
Is it okay now?
Yes, sir.
Dr. Agde?
Yes, sir.
You can see this is what I am doing. I am reflecting the mucoperiosteal flap. See, if there is no tear in the periosteum of the mandible, the bleeding will be very, very less when you will be doing the reflection of the flap also, okay?
Yes.
I'll be doing some amount of reflection on the lingual side also, because as we'll be doing a crestotomy in this particular patient, because you can appreciate that will be better. Take this flap in your retractor. Yes. Sister, give me straight hand piece. But
यहाँ पर गॉड में ले लीजिए
sorry.
बहुत अच्छा दिखता है कैमरा आगे पीछे हो जाए
Start. I have started doing crestotomy now.
थोड़ा आप लाइट से उधर से मारिए ना ऐसा प्रॉपर्ली दिखेगा
Sister, आपने पास कुछ देना कार्बाइड भरे करते
सिस्टर बड़ा वाला भर दीजिए कार्बाइड
मेरा मेरा नहीं मिरर
आपका ना
But to be very careful at the time of extraction of the teeth, so that there should not be, as far as possible, fracture of the alveolar cortices. This is what we call it as a Stobius technique, and I'm just trying to give the forces on both the teeth.
हाँ
So this is the canine which I have removed. So I think it is about 13 to 14 millimeters.
Yes.
Okay.
Yes.
And I have exposed cristotomy this time.
यस
Just go on smoothening the bone. At the same time, there should not be any trauma to the lingual tissue also. Okay, so that is the reason why I have reflected the lingual mucoperiosteum also. Sachin, stop करो बस. Sachin, stop करो यार. Stop. Okay, properly here on Sachin.
आपने
So
इधर
we will be
दो
doing
साइड में रिफ्लेक्ट करो
to the interdental bone also.
Yeah, that also I am going to remove. Okay, I'll show you once it is finished what I have exact. Can you see? This is the interradicular bone. This is the interradicular bone.
ठीक है
And I am going to remove that also. Okay.
Align the sister. Align.
Stop. So from where the inferior alveolar nerve, from where it comes through the mental foramina, and this is the mental nerve which I am going to dissect, so that we can have a fair idea about the area where we are going to put an implant. Can you see this? Can you appreciate?
A little bit of retraction is required, sir.
Yeah. Can you see this? This is the. Can you see this
Yes,
thing?
sir. Yes, sir.
This is what the mental nerve on the left side. Okay.
Yes, sir.
Which comes through the mental foramina. Okay. And it is said that about the nerve loops about 2 to 3 millimeters. Okay, about 2 to 3 millimeters. So what we are planning to have one implant here, somewhere here,
Yes, sir.
one implant in the center,
Yes.
and one implant somewhere here in the opposite side premolar region. Okay. So this is what we have planned for this patient. That is the position A, C, and E. The treatment plan is already discussed, and we'll be going to give an overdenture with a ball and socket type of attachments. See, whenever we plan any implant surgery, it should be a top-down approach. What we called it as a always keep what is the end and then plan your surgery. So one should always plan what type of restorations we are going to give, so that the selection of the implant, the diameter of the implant, the length of the implant, and the surgical site can be selected and the implants can be placed. Okay. What the reduction gear handpiece exactly do is it reduces the speed, but at the same time it increases the torque. Okay. So that the bone cutting should be with minimal trauma, and we will be avoiding the overheating of the bone. We are using two irrigation systems. So here you can see I have two sleeves. One will go in the external irrigation system, and this is another which will go in the drill as an internal irrigation system. Okay. So we must always use the external as well as the internal irrigation system, so that the coolant will reach up to the area where the bone is. We are going to cut the bone, and there should not be overheating of the bone. We want to avoid overheating of the bone as far as the success of an implant is concerned.
जरा मोटा टेप आएगा एक मोटा आएगा
दिखाइए सर
मोटा पाइए
I will just
नहीं
brief.
सर थोड़ा ऐसा टिल्ट करके इसके शेड पूरा उसमें लाइए हाँ नहीं देखिए
ऊपर लाइए
थोड़ा ऊपर
Zoom out करो।
ऊपर प्लीज जूम आउट है
zoom out है ना.
एक मिनट लाइट बंद करो.
This is the surgical kit which we
लाइट
are
बंद करेंगे
using.
सर. देखो ये लाइट बंद करेंगे.
कर दीजिए,
अच्छा
कर
दिखेगा.
दीजिए.
थोड़ा ऊपर लाइए सर. नहीं
यहाँ लाइए.
It's an easy system of
Yeah, EZ high tech.
Yeah.
I think most of the people must be knowing about this system, but just for the students, I am going to tell you that like this is a system which is having the drills. This is called as this is a round drill called as a drill used for the preparation of the countersink. Then we have 2 millimeters. Can you see this?
प्रॉपर्ली.
This is a 2 millimeter pilot drill, and then we have 2 pointed. Then 3.2, 3.65 and 4.3. Okay, the implants which we are going to use with this particular system all are the threaded implants. The anterior mandible is the best choice for the threaded implants because in most of the patients the type of the bone according to Carl Misch is a D1 or in very few patients a D2 type of the bone. Okay, so the threaded implants are best in this particular type of the bone. Usually in D4 type of the bone we use the tapping implants. Okay, so what I will be doing is I will be preparing a countersink with the round burr, and I am going to identify the areas where I am going to put the implant first. Then I will be using 2 millimeter pilot drill, and then I will determine the length and the direction where I am going to put the implants, and then accordingly sequentially I am going to increase the osteotomy site, and I will come to the final drill so that I can put an implant. Usually all the threaded implants, they have the size of an implant bigger than the size of the drill. Okay, and yeah, internal irrigation, the saline is pumped into the drill as well as outside the drill so that there is a copious amount of the irrigation. Okay, can we see? Can you appreciate?
Yes, sir.
So now I'll just
ये अच्छा दिख रहा है.
I'll just mark the areas where I'm going to put the implants. Start. Start. So this is the first. Stop.
इसका बड़ा टिप लगा दो.
One more thing about this EZ implant is we don't have a control on the length. Okay, the reason is some of the systems they provide the sleeves. Okay, but here what they have done is they have marked the things. Pump बंद कर देना.
Sir, just a small question. Would you have preferred a surgical stent, or are you comfortable working this way?
Yeah, as far as the implant overdenture is concerned, preferably as far as the principles of placement of an implant denture is concerned, see the first implant that is in the position C is usually at the center of the ridge. Okay, that is the area where the lingual frenum is present. Okay,
Yes, sir.
and then as far as the principles is concerned, we can go about 8 millimeters from the first implant, that is at the side B and side D, and we can go again about 8 to 10 millimeters from the side B and the side D, that will be your side A and side C. Okay, and that will serve your purpose. Okay, now I have marked the sides. Okay, can you see?
Yes, sir.
Can you appreciate that?
Yes.
I have marked the side. This is my first side.
Yes, sir.
This is my second side, and this is my third side where I am going to put. These are the extraction sockets. Okay.
Yes, sir.
And we have about 3 to 4 millimeter of the bone in between the area where we are going to put an implant.
Correct.
Can you see?
Yes, sir.
And this is the drill. Just stop that pump and start. Okay. Start. I just wanted to show the students how to identify the length in this particular system. Now,
फिर सर दूर ही रखिए आप उसको.
दूरी रखो.
ये देखिए अभी बताइए.
Start. Take it as close as possible. Can everyone see now?
Yes, sir.
When the drill starts, we can see different markings which are visible on this particular drill. Okay.
Yes, sir.
So the first marking from the tip of the drill is of about 8 millimeters, okay?
Right.
The second marking is about 10 millimeters, okay?
Yes, sir.
The third one is about 13 millimeters and the last marking is about 16 millimeters, okay?
Right, sir.
So when we'll be putting a drill, what we'll be doing is we'll be checking whether we have achieved a proper depth in the bone or not by visualizing these markings, okay?
Yes.
You got it?
Yes.
So now I'll start preparing this. Like, can anyone from the students, especially the postgraduate students, if they are present over there, start from.
Why the pilot way about 2 people? So I think the answer is,
Yeah.
if need be, you can change the angulation.
Basically, what the literature says is, you can see like how I am drilling in the bone now, okay? I am just going in and coming out, okay? Just going in and coming out. This is what we should do in a D1 type of bone usually.
Overheating is preventing of overheating of bone.
Yeah, overheating of the bone. You can very well appreciate, you can even visualize those markings also, okay?
So that lower lip cannot be retracted a little bit more. Yes, that's clear now.
Clear, no?
Yes.
Yeah. See about that, why the diameter of the drill is 2 millimeters. I have reached about 8 millimeters. Once you achieved a final depth, to check whether the osteotomy is proper or not, we can compare if we are doing a single tooth implants, the angulations with the surrounding teeth, like the mesial and the distal tooth, okay? And we can check the antagonist occlusion also, okay? You ask your patient to close your mouth and you check the occlusion also, because what we usually want, there should not be any crossbite. Like when we'll be putting an implant, there should not be any crossbite, okay?
Yes, sir.
Now what I'll be doing is, I'll be taking this particular paralleling pin as a guide and I'll be putting my second osteotomy, okay? Can you see now?
Yes, sir. Yes.
Start. This is second osteotomy which I have prepared. Show you. Start.
Sir, can you see?
So, can you see the third osteotomy site also?
Yes, sir. They're looking very
Yeah.
parallel.
Now I have prepared, I have achieved my depth. See, if you want to do any changes in the angulation of the placement of an implant, this is the time when we can change the angulations if required. Okay, if we are not getting a proper parallelism in between the teeth and an implant, or an implant and an implant, we can change the angulation little bit at this particular stage only when we'll be using the second drill. Okay, but if you want to change the angulation when you have done the final drilling, that is not possible. At that time you have to change the osteotomy site directly. Okay, so there is no scope. So this is the only step where we can change the angulations also. Okay,
Yes, sir.
so I think I am having the fairly acceptable parallelism in between 3 implants.
Absolutely, sir.
And now I'll start sequential enlargement of the drill, osteotomy with the drills. Okay.
Yes. So just a point for concern, sir.
Yeah.
Is bone that is exposed for that long a time, do you have to constantly moisten it, or is that a problem that will cause resorption later on?
Sorry.
The bone in the anterior region,
Anterior region. Which anterior exactly?
the lower anterior region, sir, since the flap has been raised,
Yeah.
for how much time can it be raised like that? Is there a concern for resorption later on?
So definitely there is some amount of resorption. Okay.
Yes.
But the resorption is very minimal. Say at the end of first year it is only 0.1 millimeters.
Okay.
And as the time goes and the implant is loaded with the normal physiologic forces, the resorption is very minimal as the time goes on. Okay.
Right.
So during initial time only, at the time of healing, only 0.1 millimeter of the bone is supposed to be resorbed. Okay.
Okay.
So that is the reason when we will be doing a second surgery for this particular patient, we will not be opening a flap up to this level. Okay.
Yes, sir.
And we'll be just giving the incisions in the area where we are going to put the gingival formers, and which will be subsequently loaded. Okay.
Yes.
So at the second stage, it is very important that the mucoperiosteal reflection should be as minimal as possible.
Very good. Very good.
One more. 2.8 है ना? Okay, once the 2 millimeter pilot drill is placed, then it is very easy to enlarge your osteotomy site. Okay. And it is always good that if the blood is coming from the osteotomy site, it is always good. It is always good. The reason is some amount of the overheating of the bone can be avoided by the blood which is coming out of the socket through the bone also. Okay. But there should not be a profuse bleeding definitely. Okay. If there is profuse bleeding, it means we have traumatized a vital structure in that region, and mostly it is the inferior alveolar nerve. You can see very easily now I can enlarge the osteotomy site once the pilot drill, is properly, the osteotomy is prepared properly with the pilot drill. Okay.
Is it end cutting, or is it safe? Is it blunt ended?
The 10 grams. So, a scope to enlarge an osteotomy site, and that is the reason why I have planned that I'll be putting an implant of 4.2 millimeter diameter with 10 millimeter length. Okay. So this will be my last drilling sequence. Start. you have to be very much particular about the depth of the drill, okay? And you have to visualize properly how much exactly you are in the bone, okay? Yeah, over. I just wanted to show them to you the 10 millimeter diameter implant.
Yes.
sir.
Okay, can you see now?
Yes.
पीछे एक वो रख देते
Okay.
हैं बैकग्राउंड
This implant
नहीं
it
नहीं पैकेट कैसे
always comes in a double sterile pack. Okay, so once the outer covering is open,
नहीं नहीं रहने
the unscrubbed person should not touch the inner two coverings. Okay, so I have already opened the first
यस
the first covering which was present, and this is the second covering which is in a, say, what we can say, in a vial or a plastic cylinder. Okay, and now I'm going to take out that implant. Okay, this is what we are going to put in the patient now. Okay,
yeah
can you appreciate?
Yes, sir.
So this is the implant which comes with this is a cover screw,
Yes, sir.
and this is an implant with a mount. Okay,
Yes, sir.
so initially this mount is used in the initial threading of an implant into the bone. Okay,
Yes, sir.
and once you are sure that you got the primary stability, you can take out that mount and then do the final tightening with the help of your ratchet.
Yes, sir.
Right?
Yes, sir.
As far as possible, this implant should not be in the extraoral environment for more time, and it should directly go in a patient's mouth when it is opened. Okay?
Yes, sir.
Because it is said that the titanium is more the initial. Don't touch the instruments. As far as possible, don't touch even your surgical instruments to the titanium surface. Okay? Now what I am going to do is, I am going to take out the mount because I got the primary stability initially with my hand. Usually this is the hex driver. Okay, can you see?
Yes, sir.
The hex driver is kept in the mount, and we do the unscrewing, that is called as a anti-clockwise movement. Okay, with the anti-clockwise movement I can now easily take out the mount which is present. Okay,
yes
so this is the mount which I have taken out. Okay,
Yes, sir.
this mount is mount was present on the implants in the inner aspect of the implant.
Yes, sir.
And the implant, as far as the structure of an implant is concerned, the implant is having the crest
Yes.
and the body of the implant and the apex. Okay,
Yes.
depending upon what type of implants we are using, whether it is threaded or whether it is a tapping type of implants, placing an implant is at its final position. Okay,
Yes, sir.
and this is a ratchet which is used. Okay,
Yes, sir.
one should always keep in mind that whenever we'll be using a ratchet, you can see on the ratchet there is, can you see there is one marking on the ratchet?
राजन एक मिनट मैं करता हूँ ना, तुम मत कर. हाँ थोड़ा हाँ दिखाइए सर, थोड़ा आगे लीजिए.
ठीक है?
मार्किंग कहाँ है?
So there is a marking on the ratchet, can you see?
Yes,
So this marking tells you about the direction when you are doing the final tightening,
Yes, sir.
and it should be always in a clockwise direction.
Yes.
Okay, ठीक है, यही काम है. I have placed the hex driver into the inner surface of an implant,
Yes, sir.
and this is the ratchet, and I am doing slowly tightening of the implant. Okay, and you can appreciate the implant is easily going inside without any pressure, any force. Okay,
Yes, sir.
it means it is engaging the bone over there. At the osteotomy it is engaging the bone
एक मिनट
and easily it is going. Okay,
Yes,
सर थोड़ा स्लोली दिखाइए. हाँ हाँ यस ओके सर ब्यूटीफुल. यस
what we usually do is we keep about 0.5 to 1 millimeter of the alveolar crest of the crest of an implant above the alveolar margin. Okay, so can you appreciate now?
Yes, sir.
So this
Sir,
is,
एक मिनट
I'll give one more
दिखाना
turn.
Yes, beautiful.
I'll give you one more turn to this. Half a turn will do. Yeah. Okay. Now this is the final position. Now what I'll be doing is, I'll be taking out the cover screw, which is available with an implant. Okay.
Yeah.
This is the cover
Yeah.
screw. Take out
Yes.
that with the help of hex driver, and then directly.
Left hand से करेंगे sir.
Left hand
Possible.
Just let me put. Okay.
Yeah.
So this is what I hope I'm going to put a cover screw.
Yes, beautiful.
Got it?
Yes, sir.
And once you put a cover screw, we must check for the primary stability. Okay. This is the type of sound. I don't know whether you can hear this particular sound or not.
Yes, sir. Yes.
You can hear.
Yes, sir.
You can see this is the sound which should be there. The tapping should not be dull.
Yes, sir.
Okay, it should be a stony rock, what we can say.
Yes, sir.
And this gives an idea that our implant is having a very good primary stability. Right?
Yes, sir.
Now I'll go for the second one. Another ratchet, that is a prosthetic ratchet. You can see.
Sir, थोड़ा.
So this is a ratchet which is called as a surgical as well as a prosthetic ratchet. Okay.
Yeah.
The previous one which I have used is only a ratchet which is used for the surgery. Okay.
Sir, दोनों सामने लाइए ना.
And you can see this particular ratchet is having some markings. Okay.
Yes, sir.
And there are the markings which are ranging from 10. Can you see?
Yes, sir. A little closer there.
Yeah.
Yes. 10, 20, 30, 40. It is like that. It is Newton centimeters. Okay.
Yes, sir.
So usually for final tightening, what we do is we are using a force ranging in between 20 to 30 Newton centimeters. Okay. The force should not be more than that. This is very important. Okay.
Right.
So this particular ratchet also can be used. You have to be a little bit careful at the time of taking out the mount. Okay. Just relax. Sorry. 10 मिनिटाचं काम राहिलं आहे. ठीक आहे ना? काही आहे का तोंडा? Just relax. काही आहे का तोंडा? नाही ना? इसको just relax. But I'll wait for 2 minutes. If you want, I'll wait for 2 minutes. Let me finish with this implant, then I'll wait for 2 minutes. Okay. So what is the peculiarity of this surgical and the prosthetic ratchet is, when the excess force is applied, it automatically breaks. Okay. So the excess force will not be transmitted to the implant, and that to the osteotomy site. Okay.
Yes, sir.
Another important thing is, if there is some amount of the bleeding, that blood should not go into the inner surface of an implant. This is again very important. Okay. So this is the inner surface of an implant. Okay. Because as we are putting a cover screw over there, that blood will get clotted, and there is possibility that the microbacterial accumulation may take place into the inner side of an implant. Okay. So if you have some doubt that there is some amount of the clot or the blood inside the implant, before putting a final cover screw, we can irrigate that particular thing with the help of normal saline, and then we can put the cover screw.
Yes.
Give me the last two. Sachin? Give me some saline.
along with the
third implant. Okay,
Very clear.
and we'll prepare for closure now. Before closing, whatever the debris are there, whatever the bone dust is there, that needs to be curated out. Okay, irrigate the site properly, and then close it with air pump. Usually what I am using is the 30 Marcel or 30 Vicryl suture with 25 mm of the needle. Round body needle.
Just a query, sir.
Yeah.
Some surgeons do advocate pocket protection measures and pocket preservation measures and to graft at this side. Is it really necessary? Pockets of
See, as far as my experience is concerned, see, I have done about 8 to 10 cases in an immediate extraction socket in molars also. Okay. So I have used only one of the sockets. Say either it is a mesial or the distal socket of the molar,
yes, sir.
with a broader size of an implant, of course.
Right.
So till now I didn't get any failure in that particular. Okay.
Yes, sir.
So if you graft, it is well and good, but if it is not grafted, that will not do much. Like there will not be any problem at the time of healing. Okay.
Yes.
Because this is anyway is going to heal how the normal extraction at some amount of the bone resorption. The presto, no, I will not advise that at this particular stage, because our primary concern is about the healing of an implant now. Okay. If we will be doing the second surgery in the form of say vestibuloplasty or something like that, there is possibility that some amount of, because vestibuloplasties they can be done with different techniques like Kajan-Jayan's obligations technique. There are so many techniques. Okay. So usually some amount of the bare tissue is always there in a vestibuloplasty. Okay. So usually it is not advocated as far as this particular type of surgeries are concerned. Okay.
And if we were to plan, say, if we found that the zone of attack gingiva
Yeah.
would be less, then roughly how much time would you wait for planning that second surgery?
Sorry. Zone of
If we were to find that the zone of attack gingiva is inadequate.
inadequate means how much you mean to say, like whether it is 2 millimeter, 3 millimeter.
Yes, about at least 2 to 3 millimeters.
Yeah.
Not in this particular case, sir, but suppose we did find that it was less.
Yeah.
If you would like to do a surgery for that, how long would you wait to do that surgery? Would it be after 4 months again?
After doing a vestibuloplasty, you mean to say?
No.
Then
Either a vestibuloplasty or increasing the zone of attack gingiva, sir.
I think we can wait for about 4 to 5 months.
Okay, sir.
So we'll increase the time,
Yes.
and then you can go for the placement of an implant. Okay.
Okay, sir.
Usually we start in the center. Okay. We try to approximate both the lingual as well as the labial frenum if present, and then we can suture the remaining sides. Okay.
Tissue sister.
Both of my assistants are very good. Huh? They have done a fantastic job. The reflection is very good.
Actually, the surgery has gone off fantastic, sir. Even we are having a good time.
Thank you very much. And even the projection is, I think, well appreciated. Huh?
Yes,
Thank you, sir.
It was very clear, sir.
I think he is going to write some CDs. You are going to write some CDs.
Yeah, yeah.
is going to prepare some series of this particular surgery also.
Yes, sir.
मैं आपको भेजूंगा.
हाँ जी. Any queries? Like we were talking about the diameter of the pilot drill. Most of the companies, they have the first pilot drill of 2 millimeters. You must be wondering why the other drill sequence is not same. Say it is 3.2 for one company, it is 3.3 or 3.5 for another company. But most of them, they have a pilot drill of 2 millimeters only. The reason is when, like there are so many studies which have been carried in the literature, the people have tried 1 millimeter drill, 2 millimeter drill, the bigger than that 2 millimeter, 2.5 millimeter drill for the preparation of the first osteotomy by using a pilot drill, okay? So what they have found is the temperature which is generated at the time of preparing an osteotomy with 2 millimeters is ranging about 45 to 50 degrees Celsius, okay? And at this particular temperature, usually the denaturation of the protein is not there, okay? Why there is overheating of the bone? It is just because the overheating of the proteins which are present in the bone, that is called as the denaturation of the proteins. And that denaturation of the protein will be a reason why in the ultimate post-operative period there will be the failing implant which will not get osseointegrated with the bone, okay? So this is the reason.
बस बस हो गया, खत्म हो गया.
Second important thing is we must use only the normal saline. Other irrigating solutions like they say ringer lactate or something like that, it is not advocated. Normal saline, it maintains the physiology, the pH of the tissue where we are going to do the osteotomy, and as it is isotonic saline, it will maintain the pH as well as it will prevent the overheating of the bone. See, in extreme climate conditions, what we can do is like in a Nagpur where the temperature is more than say 45 or something like that in the summer, we can keep that particular normal saline bottle in a freeze. This is how the suturing is completed, okay? If any tissue tags are there, they can be cut. Like this is fantastic. See, the suturing should not be too tight and it should not be too loose also, okay? Because if some amount of the ooze or some post-operative edema is there, that oozing should come out of that particular suture line, okay? If it is too tight, then it will get collected and there will be large hematoma and swelling to the patient. And if it is too loose, there is possibility of the accumulation of the food debris, and that may lead to the infection also, okay? So it should not be too tight and at the same time it should not be too loose also, okay?
So and how long will we retain the sutures?
See, these are all vicryl sutures, okay? Vicryl usually get resolved at the end of, say, it takes about 30 days to 45 days, okay? If the patient is coming for the recalls after 8 to 10 days, I will definitely advise to go for the removal of the sutures after 8 to 10 days, okay? But like in sometimes the patient, he is from say outside the country or something like that, he cannot report to us, then the vicryl will stay there and after 1 month automatically it will get resolved, okay? Okay.
Yes.
Yeah. Thank you.
Okay, sir.
Thank you, Dr. Agde. Yeah. Hello, Dr. Agde.
Yes.
You just see like how the surgery should be done under strict surgical aseptic and sterilization protocol, okay?
Yes, sir.
This is what everything is covered with the towels and gowns.
Yes, sir.
All the instruments are autoclaved, okay?
Yes, sir.
All the gauze and everything is autoclaved, okay?
Yes, sir.
And the surgeons, the assistants, even the non-scrub sisters and everyone should be in a OT dress, okay?
Yes, sir.
And this should be the protocol which should be followed for the surgery. These are all these two are my assistants. I think Dr. Sachin and Dr. Santosh. Santosh, everyone must be knowing. Dr. Sachin is currently working as a lecturer at my college. He is my postgraduate student, and he recently passed from my college only. Okay. Yeah. Thank you very much.
Thank you, sir. I would also like to thank the patient for his cooperation.
Yeah, patient is very cooperative. Thank you, Mr. Kale, for cooperating me. And because of you only, I could do a surgery in a very nice way. Thank you very much.
Dr. Kapurkar, Dr. Balaji here.
Yes, sir.